Good morning, everyone. Good morning, JC. Thank you so much for being here. So just briefly wanted to introduce our speaker today. So Dr. Juan Carlos Perez Lozada, he's an associate professor of vascular and interventional radiology at the Yale School of Medicine, and he's the medical director of the Yale Health Outpatient IR practice at Park Avenue Medical Center. He was recently also appointed as the Vice Chair of Diversity, Equity, and Inclusion of the Department of Radiology. JC specialized in interventional oncology, interventional pain management and spine interventions, venous sampling, and endovascular dialysis interventions. And while he's active in all aspects of vascular and interventional radiology, JC's current major interests are embolotherapy of fibroids and malignancies, as well as other minimally invasive treatments for tumors, such as local ablation, particularly in the liver, spine, and kidney. He received his MD from the Universidad Nacional Pedro Henrique Urena and completed his residency training in radiology at St. Vincent's Medical Center, which is part of the University of Connecticut School of Medicine in Bridgeport, where he was chief resident in his final year. He then completed a fellowship in vascular and interventional radiology here at Yale School of Medicine in New Haven, and then stayed on as a faculty after. And most importantly, JC is really known as one of the most talented IRs in our department, and is really an amazing teacher. And I've really had the pleasure of learning from really a lot from him. And I'm really looking forward to him going to Tanzania later this year and share his knowledge and skills there. So thank you so much for being here today. Really looking forward to this.
All right. Well, thank you very much for that introduction. He actually did it better on the spine people. So when I talked to Fabian and I asked him what is the whole talk about, he said just do cases and quiz people. So you know, my way of quizzing people is not at all meant to be for you to feel bad. If I don't know what you are trying to say, please, you know, elucidate and let me know. And if I feel like you're getting stuck, you can always ask for help from other people. This is just meant to be for you guys to kind of like see cases and, you know, so that we can learn something all together. All right. So it's not meant to be picking on people whatsoever. And that's kind of like my style of doing board reviews and doing some interactive conferences. So these are my disclosures. We're going to start with a few cases right off the bat. Let me see if I can just take this off. All right, so this is an 81-year-old female whose status post fall in the bathroom with severe lacerations to the scalp and large posterior hematoma in the upper neck and back. And hopefully I can see if this goes away. Hopefully I can play this. Oh yeah, it works. First time. So you guys can see, I'll play it again. So you can see that the patient has a large hematoma in the posterior and superior aspect of her back on the left side. She was not hemodynamically unstable at that point, but it was growing in size. So we decided to go ahead and continue with treatment. So again, hematoma on this side, hematoma right here. Maybe I can do the pointer now. As always, we usually, most of the time, goes through the groin to kind of like do some of the trauma patients and patients that we have to actually access really quickly. So this was her entry side. We always want to be at the level of the femoral head to entry your common femoral artery. You see the sheath. We always do a run around the sheath area just to make sure that we are in the right place and that we puncture the way we like it. So if we need to close or use a closure device, we will be able to do that. So this comes as a first question for any of the senior residents What are we injecting here right now? And where do you think we're trying to go? Ivan, Eric, Asa, you can phone a friend as well. So what do you think is going on, and what do you think we're injecting right here? So I'm going to give you a little bit of sort of pointers here. So you can see the catheter going above and around the aortic arch. We actually have a catheter pointing up. So this is an LAO view just to make sure that we actually see the vessels of the aortic arch, and which will be this vessel right here. Remember that the hematoma and the stuff that we want to see is on the left side.
Yeah. Is it the vertebral artery?
Correct. So you are correct. This is the vertebral artery. Once you get into the subclavian, sometimes this catheter right here, which is an H1 catheter, gets into the area of the vertebral artery right away. And depending on the tortuosity, she's an 81-year patient, you will see this popping into the vertebral artery. So this is what it is. Perfect. So we decided to probe a couple of vessels that are around this area. This other vessel was evaluated, and I'm going to ask you a couple of questions at the end just to let you know what type of vessels are. So here, right here, what do you think we're injecting right now? So we are going and making the turn and entering this vessel. We passed the vertebral artery. Perfect. So we are actually injecting the subclavian artery. And as you can see right here, we're kind of like got into the vessel that we needed to get, which is, if you see the whole hematoma area, that's where it was. And then we embolized this vessel right here, which I'm going to show you in just a few minutes. Hold on. So these are the vessels that we were trying to get in to embolize the patient. So do you know which vessel is this? Sometimes it's easier to see it in a little picture.
The which one? The one that goes vertical?
Yeah, the ones that goes up, that is kind of in pink right here.
Oh. No.
No? All right. So that's the thyrocervical trunk, which is the vessel that we were trying to sort of like trying to get into at the time that we did the procedure. And this vessel right here, anyone knows? Pass, phone a friend.
Asa.
All right, so I'm going to show you that's the thyrocervical trunk, which is the vessel that we were trying to get in. So the thyrocervical trunk was the first vessel that we injected right around here. Here. And then the second vessel that we actually got in, which is the vessel that we decided to embolize because it was actively bleeding at the time, was this vessel right here, which is the suprascapular artery. But in reality, the vessel that we were finding and we knew from the CTA that it was bleeding was this. Anyone knows which vessel is this? It kind of goes around down the scapula and on the side of the scapula, which is the vessel that we ended up completely embolizing at the end of the case. And I know this is the weird anatomy that people don't really realize, but people do fall. And I had a back-to-back two patients in the same area, hematomas, 80 years old, that didn't want to take their rug outside of the bathroom, even though it was recommended for them to do so, and they just fell. So anyone know which artery is this? All right, so you have this one is the suprascapular artery, which we already kind of pointed out. And this one right here goes around and to the side of the scapula. So that is the dorsal scapular artery. So that dorsal scapular artery, when people have scapular injuries or injuries in the mid part of the posterior chest wall, then you will have that artery frequently injury. Usually it's not going to be a big deal unless you are in anticoagulation or the patient have a really severe trauma. So that is what you usually get. So that's the dorsal scapular artery. So I'm going to try to go from top to bottom. You're going to see that sometimes my slides will kind of like share something else around that same area. So let's see if we have time to go all the way down to the legs. So this is a 58-year-old male with past medical history of hypertension that presented with was about a month of exertional dyspnea, chest pain. He reports of being in his usual state of health prior to the onset of the above symptoms, but he noted that he had an intermittent white phlegm containing cough. However, he has been intermittently coughing blunt tinge over the last few mornings. So he reports about being a smoker for a long period of time, 35 years, had no recent trauma, had no recent immobilization, no previous cardiac stress test. But he was describing a pressure on the substernal area, no chest pain, no orthopnea, no dyspnea, just the pressure. So this is his scan. Hopefully I can play this. This is going to be the patient scan. And I don't know if you can actually see what the issue is. So he did not know that he was having this mass right here. So of course the patient eventually became so the patient eventually became a little bit hemodynamically unstable and started to have hemoptysis. Hemoptysis became really something that was really of concern. So if you guys have someone for hemoptysis, which artery is the artery that you guys are going to interrogate first?
Bronchial artery.
Correct. So the bronchial artery is the artery that, for the most part, will be the artery that you will try to interrogate initially when you have a patient that has hemoptysis. So this is the artery that we actually went for. So over here you have an aortogram, and it's bad that you guys cannot point out, but this is your artery. And if I ask you which one is the artery that you will see the most on a bronchial artery type of picture, what will be your answer? If I tell you the artery that's most commonly seen on patients when you do bronchial artery is? The what?
Posterior intercostal.
So there is a name of an artery which usually comes out that is called the intercostal bronchial tree. And that is the artery that most of the time when you inject the bronchial arteries, you will see. And we'll go over that in just a minute. So this is the bronchial artery. As you can see, kind of goes all the way to where that tumor is, which is presumably the area where he was bleeding. The patient did have a bronchoscopy, and this demonstrated blood coming out from that area, but they couldn't see where exactly the blood was coming from. So if you decide to treat this artery, how would you do it, and what would you use?
So
Okay. Bronchial, I use particles because of have the tendency of recurrence. So,
Correct. So How big of a particle do you think you will use?
250.
Okay, so I will use something a little bit more close to the 300 particles. 250 is sort of like a little bit closer to the lower size that I will probably use. If you want to go safe, you can use anything that is above 300. So this is the artery that we injected. Of course, we wanted to get more selective. So we got more selective to start embolizing close to where the problem is. You can see the big mass, sort of like it was vascular, and it was making this staining and also rapid draining of it. So more so to use larger particles than small particles when you see that drainage. So the artery was embolized with particles. You can see some of the partial arteries that are going to be embolized. And this is the final just push of contrast just to see complete embolization of that artery. So this is another example of that. They tend to become hypertrophic arteries or hypertrophy over time when those patients have severe hemoptysis, and when they have some sort of malignancy. It could be TB, it could be related to fungal infection. So this patient actually has cystic fibrosis in this example. And those patients with cystic fibrosis have a very unique features. They can actually tell you where they're bleeding from most of the time. So just to go over a little things of bronchial artery embolization, we tend to call hemoptysis anything that is 200 mLs in 24, 48 hours. It does carry a high risk of mortality because of risk of asphyxiation. But I was taught that when it doesn't really matter too much of the amount of hemoptysis that you have. It mostly matter on how that patient can manage their airway. So a little bit of hemoptysis could be a big deal for a patient that cannot manage their airway. So yes, we tend to call, some severe hemoptysis anything that is above 200, but the majority of the patients will have a problem of managing their airways, and that's when you actually have to have an endovascular therapy. So most of the time, the source is the bronchial artery, and that's why we most of the time direct our attention to. But remember that you have a dual irrigation to that area of the lung, and you can have pulmonary and systemic arteries going to that area. And we talked a little bit about the causes of bronchial artery hemoptysis and why do we embolize. And TB, fungal bacterial infection, chronic bronchitis, sarcoidosis, cystic fibrosis. Usually what we see the most in the US is bronchogenic carcinoma and some fungal infections. But I did have several cases of patients with cystic fibrosis. So one of the things that you need to kind of like figure out is where is your bronchial arteries arising from, and it's usually around the area of T5, T6. You have to worry about the artery of Dankowitz, and I'm going to show you an example of that. And if I ask you, before I show you the next slide, which is the most common presentation of the bronchial arteries, how will be anatomically, how will the arteries be presented as? So if I'm going to give you a couple of choices, right? So choice number one, you have 2 left, 2 right. Choice number 2 is you have 2 left, 1 right. Choice number 3, you have 1 left, 1 right. So which one would you choose? 2 on each side, one on the right and 2 on the left, or 1 of each side? Which one do you think is the most common presentation for bronchial arteries?
2 left, 1 right.
Correct. So that's the most common presentation, which is the 2 left and the 1 right. And the 1 right is the one that you actually see most of the time as the intercostal bronchial tree. So that's about 80% of the people will have that intercostal bronchial tree. And which is typically what you see most of the time when you do the right bronchial artery. Just to show you and illustrate you that this is the way that most of the arteries will go. The way that you know that you actually are in the bronchial artery is that you will follow it all the way around the bronchus. So they follow the bronchus all the way once they actually come out of the aorta. And this right here is the artery of Adamkiewicz, or anterior spinal artery, which you don't want to touch, you don't want to embolize, of course. So if you see it and you're too close and you can't safely pass that, I will say you should not be doing embolization in that location. So what is the best view to actually look for the artery of Adamkiewicz? When you actually get into the bronchial artery and you do your injection.
It's a true lateral?
No, so actually, you know, the best view to look for the artery of Adamkiewicz is a frontal view. So an AP view is the best view. So if you do a prolonged injection of your bronchial artery, and if that artery is attached or coming from or have collateral from the bronchial artery, you do a prolonged injection on the frontal view, and this is how you will actually see it. So just look for it when you're actually doing the bronchial artery embolization. It will save you a lot of grief. And as we discussed before, we use PVAs, particles, and Borsfios, and we try to use something that is about 300 mark. 250 is okay, but it's kind of like getting close to the lower part of what I will use or I feel comfortable using. We don't use coils unless it's a particular situation, a patient is in trauma or something related to that. So once really severe emergencies come along, you just have to make sure that you use your best judgment. But for the most part, particles is what we use. And the reason why we don't want to embolize with coils is because you're jailing your way back into the artery. So the recurrence rate is about 15%. Some people quote more, some people quote less. And embolization is, you know, really effective. So if you actually need to repeat your embolization, you won't be able to do it as easy if you actually put coils in it. So think about that. The other arteries that I usually evaluate when I go over bronchial artery embolization and I feel like it is either too small or it's really not going to the area that actually was shown on the imagings before, or it makes no sense, try to look for other arteries like the internal mammary. I usually do evaluate the subclavian and do a shot of the subclavian in most of my bronchial artery embolizations, because I have seen collateralizations from either the internal thoracic or the posterior intercostals. So the thyrocervical trunk, which is what we saw on the first case, is also another branch to evaluate if you actually have questions, as well as your intercostal and your phrenic arteries. So another case will be a 52-year-old man with esophageal rupture in 1997. He had surgery, small bowel obstruction, lysis of adhesions. He had Burkitt lymphoma in the ileotomy in the ileum. He had chemotherapy, and for the past few years, he's been having this paroxysmal atrial fibrillation, which started first when he started having chemotherapy. He got cardioverted. I'm not going to show you the rest of the history because then it will be too telling. But this is his imaging. Trying to get to see if I can. So I'm gonna have you look at it for a little bit. For whatever reason, I tried to do also an interactive view of this, but I couldn't. Let me see if I can just, oh, perfect, this is better. So if you can actually see, this is the area where the patient have the problem that we saw. This was on a conventional CT that we're scanning in for something else that it wasn't related to the chest. That's what it was cut off right there. So if you see this, what will be your first impression on this patient?
PM.
All right, a PAVM. So that's what everybody thought it was. And I'm going to show you the picture. So remember, we actually get, again, access from the groin, go up, get into the right atrium, get into the ventricle, and then measure pressures in the pulmonary artery. So this is a pulmonary angiogram. Technically, when we do a pulmonary angiogram and we actually look for a PAVM, you will have flow going into that PAVM. Which is a different thing on this patient. So the flow, instead of going towards the pulmonary AVM, was going retrograde into the pulmonary artery. And this is what I was trying to show. And I apologize, I don't have something that is a real-time view. I just couldn't get it to work. The flow is actually going from here all the way into the pulmonary arteries, and you can see another picture of that. So what do you think is going on now? So it's not a PAVM per se, but what would you call this?
A fistula sequestration?
Okay, so it's close to what is will be a sequestration. This was a systemic to pulmonary artery. The question now is, where is it coming from? So the area right here, where do you think this will be coming from? So, and what would you think will be the cause? So I told you that this patient had, you know, multiple interventions in the past. He was in chemotherapy for lymphoma. And you can see some clips kind of like in this area. So most likely this will be what?
Fistula?
Fistula.
Yeah. All right. So this will be fistula, and we were thinking that this was a traumatic fistula.
Yep.
So we decided to embolize from here just because the patient was having some cardiac problems. And you can see the embolization. You can see then that wasn't enough. So we decided to search for something else and somewhere else. So what do you think we're imaging right here?
Along the phrenic artery.
All right, so this is the phrenic artery. Remember, any artery that kind of looks like bunny ears, it goes from the bottom all the way up into the diaphragm and sort of spanned across the diaphragm area. That is a phrenic artery. So this is his left phrenic artery. You can actually see that the phrenic artery goes all the way into the area that we embolized previously, and it was actually draining around it. So instead of using coils, we decided to use glue. So this was glued out, and this is the result of the glue. There was nothing going forward. And now you can have that. However, we are not done. What else would you evaluate? Which other arteries do you think might just give you some of that flow going into that AVM or that fistula in this case?
Are we done with pulmonary vein, artery, and the aorta?
Yes. So the pulmonary veins or the pulmonary arteries are something that I said we extensively did a search. We did a search of the phrenic, which is kind of going into that area. Which other arteries would you evaluate?
So
just to be thorough.
What about the short gastrics? As I mentioned, also short gastrics.
Okay, so yes, you were right. We actually injected the celiac just to see if there was something coming out there, but there was not. Nothing going in that regards. But remember that I told you that posterior intercostals actually will have a lot of collateral circulation. So this right here is a posterior intercostal artery, and that artery did have some of the flow extending back again into that area. So he will probably have to come back because several of those posterior intercostal arteries actually extended there. So not done yet. So just to give you a comparison of what a AV fistula and an AVM is. So this is the not typical presentation, but usually the presentation that people use at the boards to kind of like evaluate a PAVM. So you see this lesion either on CT or a plain film. Usually it's associated, even though this is the most common presentation, most people will say, you know, an abscess in the brain, just because you have a paradoxical embolus. You can actually have that. But this is the presentation that you usually have when you have a pulmonary AVM. So now we're injecting the same area or the same location. We're doing a PAV gram of the left side, and we actually are seeing a pulmonary AVM. So now the flow is going towards the PAVM as opposed to away from the PAVM. And then you can see the draining vein right here. And the typical question will be, when do you decide to embolize this pulmonary AVM? What is the size cutoff that you say, this is the embolization that I'm going to be doing because it's this size? Do you have a size in mind?
Oh, I'm not sure.
Okay. Anything that is,
yeah.
Go ahead.
I'm not sure, but that the size, I would think maybe if the size increases the risk of PAVM, maybe NAV, which is asymptomatic PAVM.
All right, so I'll talk to you in just a little bit about that. So this is the way that we usually tend to treat it. We either put plugs or coils to it. Most of the time, if we can get a plug all the way to the distal end of the artery. So some people will like to embolize the sac itself. Some people just embolize the distal part of the artery just in front of the sac. So there's a lot of techniques to embolize a PAVM. I was lucky enough to actually work with Bob White, who was one of the most dedicated to HHT doctors, and then transferred to Dr. Pollack, who's my partner, and soon to be partner of Fabian. So we are lucky that we're in an HHT center. So HHT could be could show a pulmonary AVM that could be simple or complex. 15 to 30% of HHT patients will have a pulmonary AVM, but if you have a pulmonary AVM, that doesn't mean that you have HHT. You should be evaluated for it. But the target number that we usually look for, and it's always in the literature, is about 3 millimeters. So anything that is above 3 millimeters, you should treat. Anything that is symptomatic, you should treat. Most of the time, you won't have brain abscesses, but it's the best way to actually show a case. So 5 to 9% of those patients will have brain abscesses. Stroke in 18% and TIA in 37%. And then embolization will be done with either coils. We don't use detachable balloons anymore, but that's something that was used in the past, and plugs. Most of the time we try to get plugs or those long coils like some of the coils that are out in the market. One more case. Any questions so far? If you have questions, you can please stop me and just ask me. I know that people forget, at the end of the session, but during the case, you can just ask me questions about it. So this is a 27, and this is actually someone that actually came on my call this weekend. She's a 27-year-old. She gave birth to twins. She had a C-section for preeclampsia that was very severe. and then just was transferred to Yale New Haven Hospital for hemorrhagic shock. So when they actually was telling me the story, I thought it was something going on with the uterus. But lo and behold, they actually did a CTA, and they found this extensive hematoma just the anterior abdominal wall, and this active contrast extravasation in that area. So if you have to actually put a location to it in a vascular territory, which artery do you think you will go after?
Inferior epigastric.
This is inferior epigastric.
Correct. So inferior epigastric. So remember, most of the times that when we do inferior epigastric artery embolization for wall hematomas or abdominal wall hematomas, we tend not to see patients bleed. We most of the time will see an abnormal vessel or hypervascularity, but we don't see active contrast extravasation most of the times that we do. So since we're in an anatomy situation right now, so I'm going to show you this set of images. So this is a pelvic angiogram. So 1, 2, 3, 4, 5. So where you see where the bleed is exactly where it was on the CT. So you can see that vessel sort of getting bigger in there. So talking about the pelvic vasculature, usually the question that we ask is, the pelvic internal iliacs are most of the branches that we kind of go after when we have pelvic trauma. And when we do other types of embolization, like embolization of the prostate artery or embolization of the fibroids. So what is the anatomy on that? When you get into the internal iliac, you will say the anatomy will be what? And mainly because it's male and females, I'm going to ask you, what is the anatomy of the posterior division of the internal iliac?
The superior gluteal.
Okay. What else? So this is the one that is easier to remember. Anything else will be anterior division, right? So superior gluteal. Anyone else? No? All right, we're gonna go over that. Perfect. So this right here is your inferior epigastric artery, and we're going to do a shot right here. See, we're going to do a shot right here, and you can see from the inferior epigastric artery that is coming this nice little bleed right here that we found corresponding to that area. We put a microcatheter all the way, and we're able to actually cross the area where we actually had the bleed. We did put coils on the top all the way to the bottom. In between the coils, we did put gel foam just to make sure that we don't miss the little branch that was bleeding. And this was the result of the embolization. So we cut the supply going from here and from here. Sometimes you do get little branches that crosses to the other side. So just to be on the safe side, we did embolization of that. So your inferior epigastric comes in the region of the common femoral artery most of the time. So just remember that is kind of like the one that goes medially. There's one that goes lateral, which is the deep circumflex iliac. So I'm gonna just go over your little bit of anatomy, which is, this is a little cartoon that kind of illustrates most of the arteries that you wanna see. So if you have to remember something about the internal iliac, will be your anatomy here, because not only will depend for you to do prostate artery embolization or uterine artery embolization, but it's a very common area where you actually will have trauma. So posterior division have, as he said already, the superior gluteal. but also the lateral sacral and the iliolumbar. So those are the three branches that kind of arise from the posterior division. Everything else will be anterior division, your uterine arteries, your prosterovesical arteries, your obturator arteries, your middle recta, and your internal pudenda. So this is a 34-year-old male, and I'm not going too quick, right? I'm just trying to show as many cases as I can before the hour is over. So if I'm going too quick, please let me know. So 34-year-old male, MBC, his blood pressures were soft, but stable, mental status was preserved. So this patient had this film, and as you can see, you have this splenic laceration with active contrast extravasation. So we decided to actually do some embolization of his splenic artery. So we're going to go a little bit over the anatomy. So who wants to take this? Which artery are we injecting?
The celiac trunk
Okay.
at first,
All right. And which artery is this coming down?
the GDA,
Okay. And which artery is this converted into this area right here?
it's going to the gastroepiploid,
Okay, perfect. And which artery is this?
the right hepatic,
Okay. Which artery is this?
Left gastric.
So this is left hepatic. There's an artery that kind of like comes into this area. You can see it a little bit. All right. So that's the left, that's your left gastric. And then, so remember, it comes close to where your celiac artery is. And then there's an artery that comes right around here into this area.
the cystic,
So I will say that this is the cystic artery, and this artery right here will be what? So
that,
it's going into this direction right here. So it is a normal variant. It usually comes from around this area right here, but you see it right here on this side, which is great for this case. So that's the, say what? Yeah, so that's the dorsal pancreatic artery. So, and this artery right here that comes in this area of the pancreas. Yes, so there's the pancreatic magna artery. All right, perfect. So we went over the anatomy of the celiac artery. So just to remind you, we actually do want to preserve the pancreatic magna when we are doing embolization of the splenic artery. So some people call it mid-splenic artery embolization. The majority of people will call it proximal splenic artery embolization or just plain splenic artery embolization. So there's two school of thoughts of how to treat splenic artery trauma or bleeding. So if you see something that is bleeding, this wasn't actively contrast extravasating per se, but you do see pulling of contrast. So that was an aneurysm in that area. So you can do two things. You can try to go all the way to the end and embolize this as a chance of risk of bleeding. But at the end of the day, most of the people will just do a proximal splenic artery embol. So even though we went and we embolized that just to make sure that there's really no risk of bleeding, we did eventually put a plug in that area. And when you inject through the plug, you can see the pancreatic magna not being affected. So we do want to have this collateral circulation. The point of this is not trying to embolize the whole spleen, but just to decrease the pressure head that goes there so that the patient can heal without having the bleeding. And that patient did okay. Just to document, this is the American Association of Surgery for Trauma, and they do have a classification for hematomas. So we tend to treat either hematoma or lacerations that are grade 3 or grade 4. Usually we just watch and wait for the grade 1s and 2s. So you live in around this area in the 3 or 4. So just to double check and go back again, this is your gastroduodenal artery. Your dorsal pancreatic artery comes just with the proximal aspect of your splenic artery, as well as your pancreatic magna artery, which are the greater pancreatic artery. It comes about the mid portion of the splenic artery. And that's the in-between area where you want to put your plug when you actually do your splenic artery embolization. So on this case, this was a individual that was having active bleeding per rectum. Old school stuff here was that we couldn't see where the patient was bleeding on the CTA. They eventually decided to do a bleeding scan, and you can actually see the scan over time kind of like being positive in this area. So it is in the kind of like hepatic flexure area. So which vessel do you think you were going to interrogate if you have to?
The right colic.
The right colic, okay. So this is the SMA, and we're gonna go a little bit over the anatomy of the SMA. Did you by any chance see the finding? And I don't have a pointer for you to do, but it will be nice to have interactive pointers at this point. So I'm gonna point it to you right here. Is around this area. You can actually see the same area of bleed in the same location as your nuclear medicine study. But the point of this is for all the anatomy. So what is the first branch of your SMA? Anyone knows? What will be the first branch of your SMA? So most of the time, if you inject your SMA, you will have the inferior pancreatico-duodenal artery as your first branch, kind of posterior in your SMA. People take it for granted, but it is the first branch of your SMA. Unless you have normal variants, that's the branch that you sort of look for in patients that have a GDA bleed or close to a gastroepiploic bleed. Because they are interconnected. So if you actually have some bleed in the GDA region, not only embolize the GDA and look for the celiac, but also do an SMA run just to make sure that your back door of the inferior pancreatico-duodenal artery extending back into your GDA is closed. So what artery is this?
Middle colic.
Middle colic, great. What artery is this? I know it's kind of like a little bit of a different anatomy, but it will be going this way and supplying this area.
Just the right
colic.
Okay, and this one right here that goes down.
Idiocolic.
Correct. And then this branches around here will be what? Okay, and the branches around here will be what?
Branches.
Correct. So this is the simple way to sort of like describe the SMA anatomy is on your left side, which is the left side of the screen, on this side, and which is the right side of the screen on this side. But in your left side of your body, you will have, everything will be mainly small bowel. So depending on where it is, jejunal or ileum. On your right side of your body, it will be mainly all the branches that go to the colic or to the colon or the ileocolic region. So kind of like to get you a perspective of what you're looking for. So if we get into the middle colic right here, if we get into the middle colic right here, so how would you treat this patient? And then the reason why is the middle colic, because it's the only branch that kind of goes from the right to the left and kind of span the whole middle portion of the colon. So how would you treat this?
Oh, sorry.
So
Which one?
treat
Put
this
coil?
So what?
Embolize with coil?
temporary embolic.
Temporary embolic. So I will say, you know, we sort of like try to be a little bit more aggressive. We actually go all the way to the end, and we were able to actually put coils in it. So I will say the more specific you can be on treated branches of the colon, the better it is. So all the arteries that you actually see that kind of go from the main artery and to the outside are called the arteria recta. And the teaching usually is that if you take one arteria recta, you're fine. If you take two arteria recta, you're fine. If you take three arteria recta, then that's when you actually start having problems with patient getting into ischemia. So, you know, you can easily tolerate taking two arteria rectals without any problems. So let me just show you, because in the interest of time here, I'm trying to make sure that I show you another case. So this is, again, what we are showing here is the celiac artery. We're doing a contrast injection. You can see the GDA and the gastroepiploic artery as we went to all this. And this is the left hepatic artery. So there's something missing right here, right? There's a big vessel that is missing, and you do your celiac artery, and instead of having your IPDA or inferior pancreatic duodenal artery being your first artery of the SMA, you see this artery right here, which is a replaced right hepatic artery going into your liver. So this is important because it's a normal variant, and if you actually have to guess how much or how many times do you see, what's the percentage of right hepatic artery arising from the SMA will be what, more or less?
15.
Yep, you're kind of right. 15 to 20% will have a replaced right hepatic. So if you don't see it and you see that it's not filling the whole liver, there's somewhere else another artery coming, either an accessory hepatic artery or right hepatic artery arising from the SMA. So just look for them. We're going to go a little bit over the anatomy of the left. So this branch that actually goes up right here will be what? What will be this artery called? It kind of comes from this injection. Anyone?
So this is the artery, right?
The what? All right, so I heard someone said arc of Drummond or the artery of Drummond. All right, good. So this is the left colic right here, arc of Drummond. So this this one right here that goes into this area will be what?
The sigmoid.
Yeah, so those are the sigmoid branches, and the ones that go down in here will be what?
Sacral.
So those are the what? So those are your hemorrhoidal arteries or rectal arteries, all right? So the rectal arteries, remember there are some that are superior, middle, and inferior rectal, so those will connect with your internal iliacs, and this is a pathway of collateral circulation when patients have a problem of arteries being cut off for whatever reason. So it's good to kind of like learn about the collateral circulation of the body, because there are definitely plenty of ways of your body can collateralize to one place or another. So we did talk about the replaced hepatic coming from the SMA, about 15 to 20%. Left gastric is just a little bit higher sometimes, 15 to 25%. And I'm going to show you this one last case. So what do you think is going on here? So this is the arterial run of the patient. This is the delay images of the patient. And what do you think is going on?
Sorry, can you repeat? Sorry.
So this is the arterial run of the patient. This is the delay portion of the arterial run.
Is it a subclavian steal syndrome?
Okay, so you got it. So this patient right here had this area of stenosis. So on the initial view, you can actually see all the vessels filling in except for this segment right here. And then on the delay run, you actually see contrast going back and again into the subclavian, a little bit more delayed. So it takes some time for it to go around into the vertebral arteries, be a reverse flow and into that area. So we decided to make sure this patient was having symptoms and was symptomatic. So we decided to treat this patient. This was part of atherosclerotic disease. We were able to cross and put a stent on this. And this is how it looked by the time that we were done. So the only thing that to be careful is just to make sure that you do not enclose this vertebral artery that kind of comes down there. So you make sure that you actually don't do that. And the patient actually does pretty well. I actually had some other case this past weekend about the right side being thrombosed, and we were able to open that. In similar situation, we put a stent into that area. So you get symptomatic with this. You can have dizziness, vertigo, visual changes, anything that actually affects your vertebrovascular or posterior cerebral circulation. And then you will have the arm claudication and pain at rest. Most of the time, people will have a ultrasound that will show this parvostardus flow and reversal of flow. You can see it here on the ultrasound, and this is kind of like diagnostic of a patient that has subclavian steal syndrome. So I'm actually made it in an hour. So on the dot. Okay, so any questions you guys have? So I know that this is, a lot of info and a lot of questions, but this was actually just the upper part of the body. We weren't able to actually make it to the lower part of the body. There are tons of cases that you can actually evaluate the arterial anatomy. And the more you kind of questions yourself when you actually are looking at those angiograms, the better you will get at it and the better evidence to actually how to treat them and what will be the best treatment for them. Some of them are not straightforward, but as long as you see those arteries, you will actually recognize them and embolize the arteries that you recognize, you always will be safe. And with that, I will end the talk. And if you guys have questions, you can always contact me. And if you have tough cases that you want to discuss, please let me know, and I will always try to help you out.
Thank you.